A very big hello to all my dear students. So let's start with uveitis today. Give the heading uveitis. What is the uveal tissue, all of you? We all know uveal tissue is iris, ciliary body and choroid. This is what is called vascular layer or uveal tissue. So what is uveitis? Let us note down. Write down please. Inflammation of uveal tissue. Inflammation of uveal tissue is uveitis. Classification. So we can classify uveitis either, I'm writing here but I won't expect you to write on a copy there. So this is, you can classify it anatomically or we can classify it etiologically. Right? Now, come to anatomical classification. If you look at this one, anatomically, we can classify uveitis as, so this one is anterior, right? That is iris and pars plicatum. This is your anterior uveitis. When there is inflammation of pars plana, this is what is intermediate uveitis, right? Intermediate is actually a broad term which primarily involves pars plana, peripheral part of the retina, vitreous and so on. We will talk about it. We are at present understanding the classification, and posteriorly, can you see it in the green? This one is your posterior, which is involving mainly the choroid. And what is the fourth type? When all three parts are involved, that is your panuveitis. Okay, so anatomically we have divided it as anterior, note down please, which is iris and pars plicatum. Let's write here. So anterior, when you say, is iris and pars plicatum, therefore we also call it iridocyclitis. Second is your intermediate uveitis, primarily involving the pars plana, so we can also call it pars planitis. Then we talked about posterior uveitis, which is also called, which is mainly involvement of choroid and retina. So you can say it is retinochoroiditis or chorioretinitis. Primarily it is either a chorioretinitis or if retina is predominantly involved, it is called retinochoroiditis. But mainly it is the choroid involvement. If I talk about the uveal tissue, we are saying it is choroiditis, right? And when all the three parts of the uveal tissue are involved, we will call it panuveitis. This is how we are classifying it as anatomical classification. Simple? Okay. Now this anatomical classification was, this which you are studying is according to the standardization of uveitis nomenclature. We call it SUN. Okay. So this you are learning according to, this classification is according to the standardization of, according to SUN, which is standardization of uveitis nomenclature. Okay. Another important thing is this SUN is also provided us with what is acute uveitis, what is chronic, with what is recurrent and what is relapsing. We have to understand that also according to the time of inflammatory activity. We can consider uveitis as acute uveitis. I am making it a little simpler here. So within less than 3 months, duration is all acute uveitis. Okay, it is generally sudden onset. What is chronic? More than 3 months, right? That means persistent duration of more than 3 months is chronic uveitis. And let us learn here, recurrent means totally repeated episodes with inactive period in between. That is recurrent. Okay. So repeated episodes with inactive period is your recurrent. And what does relapsing means? Remission activity. Remission means nothing, no signs of for more than 3 months or more. 3 months or more than that. So no sign of any inflammatory activity, then you say it is remission. When do you define it remission? When no activity in the anterior chamber, no cells, or no aqueous flare and no inflammation in more than equal to 3 months, we can consider it as remission, right? Simple. Have I made it simple? Acute was less than 3 months, chronic more than 3 months. Then what is recurrent and when do we call it a remission? Now, there was another study which has divided it into etiological classification. We just learned now we can divide it etiologically. So, etiological classification was given by International Uveitis Study Group, IUSD. This stands for International Uveitis Study Group. Now, it says that etiologically, uveitis can be due to any infection that is infectious in nature, right? So, infection means bacteria, viral, fungal, etc., parasitic, everything. Okay. So, this is infectious. Second, of course, becomes non-infectious cause. Now, non-infectious cause may be either with systemic association or it could be just without any systemic association. Right. So, this is simple to learn. I hope you're learning along with me. And comes the third type. The third type etiologically is a broad heading called masquerade syndrome. I just want you at your level to know what is masquerade syndrome. All the situations or conditions which are mimicking an inflammatory etiology, but it is not. It is not inflammation. It can be neoplastic or it may be non-neoplastic. But it is not uveitis. It is mimicking uveitis. Okay. So, or non-neoplastic. So, this is about your different classifications. So, one by one, once you know this, how you can classify uveitis as anterior, intermediate, posterior and pan. We'll start with anterior uveitis. Let us start with anterior uveitis. What did you learn with me? It is also called iridocyclitis. Yes. So, anterior uveitis or iridocyclitis, of course, this is one of the, among all the different classifications, this becomes the most common form. Okay. So, this is the most common form of uveitis. How will this patient present? Just as you have learned in keratitis, all these 5 fingers are going to be there. So, this patient will come to you with a complaint of pain. There will be redness. Of course, which redness? I think I've discussed this so many times. It's a ciliary congestion. Okay. Then, photophobia, blepharospasm and discharge. Blepharospasm is closing of the lids. Photophobia is intolerance to even the normal light. We have discussed this. And discharge. What is discharge here? It is always watery if we are talking about uveitis. It is a serious discharge. And of course, there will be some blurring and diminution of vision. Right? It could be due to some corneal haze or haze in the aqueous humor, which is causing diminution of vision. So, this is how this patient is presenting to us. Okay. Now we talk about what happens on examination. What do I see? So when we are talking about this, so you can in short, you write anterior uveitis as AAU, acute anterior uveitis. So these days we write it in short like this, acute anterior uveitis. Let's try to find out the on examination finding. I would like you all to take a fresh page, make a large diagram. Let's lot of labeling here. Okay. So let's draw and learn. On examination, what you get? All of you, this is your pars pliccata, this is plana. My simple way of drawing it for you all. This is your choroid, this is the retina. Right? This is your lens. And these are the suspensory ligaments. Done. Now we talk about is what are the on examination finding. Apart from the redness that you are going to see and all those features we have mentioned, we will get what is the hallmark feature of uveitis. KPs. What are KPs? KPs are nothing but keratic precipitates. Now, keratic precipitates are proteinaceous or maybe cellular deposits at the back of the cornea. Now, this can be fine and gray. I'll show you the slides in non-granulomatous uveitis, but in granulomatous, it is large with greasy look. Large greasy KPs, we call it mutton fat KPs. Okay, so we call them mutton fat KPs, which is a feature of granulomatous inflammation, right? So if they ask you this question, please keep writing here, make a cue. Hallmark feature, write on your copy, it is KPs. Hallmark feature, we will always answer keratic precipitate. So one more thing, let's make one more diagram to understand a little more about the KPs. If this is the cornea, okay, this is your pupil, right? Now, what I'm saying is, when you look at the KPs, you see that the maximum KPs are always at the lower cornea. And there can be an imaginary triangular area where they are maximum. So first of all, this is your exam question. Why the KPs are always on the lower cornea? Why not on the upper cornea? So why the KPs are always on the lower cornea? Of course, gravity may play some role, but major because of the convection current in the aqueous humor. This is the main answer we expect. Convection current in aqueous humor is responsible for settling these KPs at the lower cornea. Okay? And this imaginary triangular area is what is called Art's triangle. This is what is Art's triangle. Okay? Got it? This is we have learned Art's line in trachoma and Art's triangle. These are the two places you are going to learn about Art's. Right, all of you? Okay, then we talk about, go back to our original diagram. What is the next finding? Are aqueous cells. This is a hallmark feature. This is a, if they ask you what is a sign of active inflammation, we should answer first as aqueous cells. Sign of active inflammation. It could be flare also, but predominantly if you have to choose, you will first choose cells. What about flare? What is the next is haziness in the anterior chamber. What is this haziness actually? Do you all remember your physics of what is Tyndall effect? Due to the random movements of the particles, which is called Brownian movement, how there is scattering of light, and that is what is causing aqueous flare. Okay, so aqueous flare is due to Tyndall effect or scattering of light. Anyway, why will this be hazy? This flare is why? What are these particles which are causing the Tyndall effect? Leakage of protein. Okay, so it is happening because of the leakage of protein from the inflamed tissue. Pay attention, which is the inflamed tissue? Iris and pars pliccata. So what is the story here? This iris and pars pliccata, which are inflamed, what happens due to inflammation? The changes in this tissue is increased capillary permeability. It is due to this increased capillary permeability, you are getting leakage. This leakage is causing aqueous flare. The same leakage is also going to lead to edema in the iris, and such an iris is what is called muddy iris. What is muddy iris? All the lines, the radial spokes, the colorate, everything is blunted and it becomes smooth like a mud. That is why you call it muddy iris. Okay? So, please remember the main problem here is increased capillary permeability due to the inflammation. Okay, then what else? What are the other finding on the iris? Meiosis, very important point. This is due to release of toxins from inflamed tissue. It irritates the iris sphincter and there is meiosis, and this is very important to distinguish from any painful red eye. Always remember pathognomic, that if there is a meiotic pupil, it has to be in uveitis. I would like you all to note it down in the box that put it in the box, in uveitis, pupil is constricted. You get a constricted pupil. The rule never breaks. Whereas if I talk, exceptions are always there, I'll let you know that. But primarily uveitis means constricted pupil. And of course in angle closure glaucoma, you have learned with me this one. So angle closure glaucoma, we get a mid-dilated pupil. We will get a mid-dilated pupil. So this generally never breaks. This rule is important, and this understanding is very important for diagnosing the two conditions. Let's come to the next finding here is nodules. Nodules on the iris. Either it is at the pupillary border. What do you call this? Copes. Copes can be present in both granulomatous and non-granulomatous inflammation. Second, what you see is at the base of iris, this is called basaka. Basaka nodule is a pathognomic for only granulomatous inflammation, right? Okay. First, let's have a look at these features before I go to the next feature of anterior uveitis. Have a look. These are the fine KPs that we are talking about. So, these fine KPs are feature of what? Non-granulomatous uveitis, right? Then this is what? This is your mutton fat KPs that you see, right? Mutton fat KPs, this sign of granulomatous inflammation. Can you also think this is the imaginary triangular area where the KPs are maximum, which we are calling at arch triangle. Look at this one. When the inflammation has subsided and still the KPs can be present. This is the reason sign of active inflammation. It's an exam question. Answer is aqueous cells. Okay. So when the KPs are present, they can after long standing inflammation, these old KPs can become pigmented and crenated. These old KPs are generally pigmented. So it is showing you some pigmented old KP. We next talk about, can you see this? This is the slit lamp light which is falling here on the aqueous anterior chamber, and these are the cells. These are all aqueous cells. Again I am repeating, it's a repeated cue. It's a sign of active inflammation. It's a sign of active inflammation. See here, the nodules are at the pupillary border. These are called Cope's nodule. Cope's nodule can be a feature of both granulomatous and non-granulomatous inflammation. And here we are, this is what is Basaka nodule. Basaka nodule we just learned is mainly seen in granulomatous inflammation. It is the nodule at the base of the iris. What next you will see after this? Okay, see a few more things in iris is when it is due to a viral infection like herpes. We are going to write it later as well. Just have a look. This is a sectoral iris atrophy involving any one sector, right? So this sectoral iris atrophy is typical feature of herpes infection. Keep in mind. You want to write it right on the diagram? Make another one. Make another one very quickly. Like this. And write down. There are two types of patterns of iris atrophy that we can see. Sectoral or it could be diffuse. The sectoral is mainly a feature of herpes and diffuse is mainly a feature of, we will learn this, Fuchs heterochromic cyclitis. We will be coming to it later. Just note it down. We next talk about is, look at this slide. So if this is the slit lamp light on the cornea, can you see the haziness here? This is what is flare. What did we learn? It is due to that Tyndall effect caused by the Brownian movement. So mainly the flare is due to protein leakage. Just remember this. This is happening due to leakage of proteins, right? And when you are talking about KPs, okay, one more point that we all can add here is mutton fat KPs. Let's go back. These are mainly macrophages. One more point, please note this down. Mutton fat KPs are generally macrophages, whereas the fine grey KPs are the lymphocytes. These are mainly lymphocytes. Okay, so another very typical feature of herpetic uveitis, apart from we just learned sectoral iris atrophy, is you may get hyphema. What is hyphema? Everybody is clear? It is blood in the anterior chamber. Okay, blood in anterior chamber. So mainly typical of herpetic uveitis. Please remember, it is typical of herpetic uveitis. So this is your hyphema. Let us note it down. Mainly seen in herpetic uveitis. Okay. What else? What are the other features? Let's draw. So let's keep drawing here. What next will happen? Apart from these features, what next? Suppose the treatment is, the patient has not presented to you, or the treatment is insufficient, has not started for whatever reason. If this progresses, the inflammation progresses, next thing that is going to happen is this iris is going to get adhered to the lens. When the iris gets adhered to the lens, what do we call it? So iris getting adhered to the lens is what is called posterior synechia. When it goes and adheres to the lens, this is posterior synechia. So the next development can be adhesion to the lens. Draw this diagram. So when there is a posterior synechia, initially this posterior synechia will, let's make a better one. So yeah, so it is, when you talk about the posterior synechia, initially suppose this is the place where there is adhesion with the lens. Maybe then slowly this is another place where there is adhesion with the lens. Please draw with me. Or maybe third, this is the place. So when it is at pupillary border, at few points it is adhered to the lens. Think yourself, if I try to dilate the pupil, what will happen? The rest of the iris is going to dilate, but these adhered points will not move. When the adhered points are not moving, this type of pupil is what is called, exam question for you all, festoon shaped pupil. Okay, so festoon shaped pupil is a feature of, what will you answer? Acute anterior uveitis or posterior synechia, when there is a posterior synechia. Okay, so what is the story next is that if nothing is done, now what is happening? It is going to adhere through the whole of the pupillary border. When the adhesion is through whole of the pupillary border as a next step, now can you think of something? If the whole pupillary border is adhered, do you realize that aqueous cannot flow anteriorly? Right? So there is a pupillary block. So first of all, this whole adhesion along the pupillary border is what we call ring synechia. And the other name of ring synechia is seclusio pupilli. It is also called seclusio pupilli. So this ring synechia or seclusio pupilli, what it is going to lead to? Think yourself. Aqueous cannot flow anteriorly now because of this pupillary block, isn't it? So the no aqueous, it cannot flow anteriorly. So it is going to collect where? It will collect in this posterior chamber. And when it collects in this posterior chamber, it is going to push the iris forward. Bowing of iris forward is what you call iris bombae. It is BE, and this will adhere to the cornea, leading to peripheral anterior synechia. What is anterior synechia? When iris is adhering to cornea. What is posterior? When iris is adhering to the lens. Got it? So, what is the story? I am repeating. First, there were few synechia, posterior synechia, then it led to ring synechia, seclusio pupilli. Because of the ring synechia, there is a pupillary block. Because of the block, accumulation of aqueous in posterior chamber pushes the iris forward. Iris bombae, it's already inflamed, is prone for adhesion to the cornea, leading to peripheral anterior synechia, which is going to cause angle closure glaucoma. This will lead to angle closure glaucoma. Correct? Okay, so have a look here. This is the posterior synechia and these are the arrows which are telling you that these are the points of adhesion to start with. Later, what did I explain? This whole thing will become a ring synechia. And when there is a pupillary block, aqueous flow is blocked. When aqueous flow is blocked, what is happening? Aqueous is collected in this posterior chamber. When aqueous is collected in the posterior chamber, it pushes the iris forward. This is iris bombae, and this will adhere to the cornea, leading to peripheral anterior synechia, which is causing angle closure glaucoma. So angles get closed. Right? Now it must be clear. Okay. Another thing that we need to draw here is when further it will progress, whole fibrous tissue is even covering this surface. When it covers this surface also, even the pupillary border is not visible. This is what we call occlusio pupilli. This is your occlusio pupilli. Okay, look here. So this one is your occlusio pupilli. When it is covering the whole surface of the lens also. Again here this is occlusio pupilli. Lastly, another last point that we have to remember is there can be a cyclitic membrane, which is an inflammatory membrane behind the lens. This is what is called cyclitic membrane. These are the features of anterior uveitis. So this is what is called cyclitic membrane, and these are the features of anterior uveitis. Okay, one more feature that we should also add on to our list is what are these? So these are new vessels in the iris. iris, which we call rubeosis iridis. So you may get this also as a part of inflammatory activity. Do you all also know what is the difference between rubeosis and what is pseudorubeosis iridis? Pseudorubeosis iridis are normal dilated blood vessels. Okay. Now down. Okay. So these are your normal but dilated blood vessels. So you will see that they are mainly radial. So these are dilated blood vessels and they will be radial. But when it is neovascularization, that can be irregular appearance. Okay. So this is how we differentiate between the two. So you may get a dilated vessels and feuds, or there may be neovascularization as a part of inflammatory activity. So we are going to talk about each condition and then I'm going to repeat these points. Right? So this could be finding. Also, can you also think with me when we are talking about the features of acute anterior uveitis, what about the IOP? So IOP in acute stage, of course, will rise, right? It can rise because of, it could be the blockage in the TM due to the aqueous cells and inflammatory activity. There can be trabeculitis. But chronic uveitis, when it is more than 3 months, there is a ciliary shutdown and intraocular pressure will decrease, right? So can we learn this? So if we talk about the IOP changes, we should say that if it is an acute uveitis, we have learned acute P is less than 3 months, we expect an IOP to rise. But when it becomes a chronic, in chronic uveitis, there is a ciliary shutdown. And when there is a ciliary shutdown, what do you mean by ciliary shutdown? Aqueous is formed less by the ciliary processes. And when aqueous is formed less, that will lead to low intraocular pressures. So let's keep this in mind as well. And what can be the most common cause or complication of anterior uveitis? If they ask you, let us answer secondary glaucoma. Most common complication, I mean to say, most common complication of anterior uveitis, we should answer secondary glaucoma. So there is always a debate on whether it should be complicated cataract or it should be glaucoma, because both occur after uveitis. We'll choose secondary glaucoma as a priority for most common complication of anterior uveitis. Okay, clear now? Yeah, right. So these are features of anterior uveitis. Before I come to the treatment part, we will have to discuss a few more things here. So first thing that we will discuss, a very quick review on what can be the systemic associations of anterior uveitis. Give the heading, systemic associations of anterior uveitis. Talking about the systemic association, let us divide it as infectious. What are the infections that can lead to? So infectious. Second, non-infectious. Okay. And third is your masquerade. Right. So when you say infectious, what are the infectious causes, infections that can cause anterior uveitis? We have to keep that in mind. We were talking about herpetic, right? So we can talk about, we can start with herpes infection. Could be varicella zoster, or it could be simplex, right? What do you call that? Shingles. We have learned this already, or it could be herpes simplex. Second, of course, tuberculosis, syphilis, leprosy, right? So all these can lead to anterior uveitis. It may not be a complete list. The important ones are listed here. I don't want you to mug it up. I just want you to read it and think about it. That's it. Okay? Because if we know these associations, then only we can understand why we are investigating and doing these tests in order to exclude these causes. So please remember, when you talk about the treatment of uveitis, if you talk about the topic of uveitis as such, treatment in majority is steroids. So that is not very big question for you. What is more important is to know the associations and also how to investigate. So investigation is more challenging in uveitis than treating a uveitis. Okay, right. So we talk about infectious causes done. Then you think with me, what are the non-infectious? You all must have already studied this. So non-infectious causes we can talk about sarcoidosis, isn't it? We can talk about Behçet's disease. 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 We can talk about Of course, HLA B27 associated arthritis. We are going to take these in detail as well, okay? Just we are listing it here. So, these can be some of the important. And then of course, why inflammatory bowel disease, Crohn's disease, ulcerative colitis. So, write down inflammatory bowel disease. Ulcerative colitis, it is more common than in Crohn's. Keep this in mind. When we talk about uveitis, it is more a feature of ulcerative colitis. Then it could be drug induced. If I talk about non-infectious, you have learned about what are the anti-glaucoma drugs which can cause uveitis, pilocarpine, latanoprost, or even sulfonamides. Okay, so it could be drug induced. Please note down about pilocarpine and your prostaglandin analogs. Okay, so these can be some non-infectious causes. We next talk about is your masquerade. Masquerade, as we have earlier also classified, can be neoplastic or non-neoplastic. So this, you know what it means? It means that it is not exactly anti-uveitis, it is mimicking. So neoplastic, there can be tumors like lymphomas, okay, or anterior segment melanomas. Then most common that we learn, very important, is retinoblastoma and even metastasis. So again, as I said, no, don't mug up, read it 2 times, it will be simple. So this was about your some neoplastic causes, right? So this pathology is mimicking, I'm again clarifying, mimicking inflammation, but it is not exactly the inflammation which is the cause. Then what are the non-neoplastic causes that we can actually list it out? So I'm giving you this list because it's one of the important lists in your very latest edition of 9th edition of the Kansky. So let's just have an idea about it. Okay, so when you say non-neoplastic, any intraocular foreign body can mimic as anti-uveitis. What else? It could be any old retinal detachment. It could be pigment dispersion syndrome, which you have learnt already in your glaucoma chapter. PDS, write down pigment dispersion syndrome, where again those pigments can mimic as KPs, and the whole picture can be that of anterior uveitis. But these are what? If you remember, I taught you Krukenberg spindles. Anyway, I don't want you to again telling you this. No need to try to mug up the list. Keep reading it twice or thrice. That is more than enough. Once we know this, we next talk about is your investigation. So talking about the investigations, if we have already pondered about what could be the association, we have to think accordingly. So if I talk about ocular of course, best is clinical examination, and what I'm seeing in the slit lamp diagnosis is based all on that. But if I want to see posterior and I'm not able to see clearly, I may go for ultrasound B scan. I may need for any posterior involvement, maybe there is angiography, I will do an OCT. We'll talk about all these in details in the retina chapter as well. So this could be needed, generally not, but yes, it can be. Then we talk about is systemic investigation, which is very, very important to understand. So again, you will just read it twice or thrice and you will know it. Nobody is going to ask you the list as such. So of course, I will start with the hemogram. If I doubt syphilis, what should I do? I will go accordingly. We will do the VDRL, TPHA and all that. Then according to, for sarcoidosis, I should go for serum AC levels. And of course, I can also do a chest X-ray, right? Then I should also be doing the LFT, KFT, and your glucose has to be seen again both in serum as well as in urine. Then for tuberculosis and all, I am doing the Montague's test. I may go for gold quantiferon test. Right? And of course, if I am doubting about the HLA associated arthritis, associated uveitis, I should go for the X-ray spine, right? And what else I should do? HLA typing, very helpful, HLA typing. So just have an idea, this is a compact and crisp list that I've given to make your life a little simple. But this is how we are going to think and what are the investigations needed. Now, a very quick and simple way of learning all the HLA association that is asked in your exam, make a box. So, if you talk about HLA B27, we all know we are talking about arthritis associated uveitis. When I say it is HLA B5, what am I talking about? Behçet's disease. But Behçet's has one more association, and that is B51. HLA B5 and also B51. Then another one that you have to learn is HLA DR4. Okay. So DR4 is this association is both with VKH, wo Koyanagi-Harada syndrome, we'll talk about in detail, and sympathetic ophthalmitis. Okay. So if these HLAs are more than enough to learn, we don't need more than this. Correct? Yeah. So that was about the investigation. We come to the treatment part. What is this? Is an important question here. Q. What is the choice of treatment of anterior uveitis? You should answer, though we know that steroids is a problem, it can cause glaucoma, cataract, but please, even today, the choice of treatment is topical steroids. We have no other way yet. Apart from that, of course, we give topical cycloplegics. I'm saying topical, everything topical, okay? Topical cycloplegics. Next question for you is, what are the role of the cycloplegic? This is what they ask you. Role of cycloplegic. So what is the role of cycloplegic? Think yourself. It is relaxing and paralyzing the ciliary muscles, right? So it gives rest to ciliary muscles and therefore will help in healing. When this happens, it relieves pain. Because of that, it relieves pain. Right? Then, because it's a mediatic, so it is keeping the iris mobile, pupil mobile. Therefore, it either prevents posterior synechia, or in some cases, if it's a fresh synechia, it can break the posterior synechia. And one more, because it is relaxing the muscles, improves blood supply, that means improved antibody supply and therefore better healing. Okay, so better healing. These are some of the roles of cycloplegics that you should know. I think this much you have learnt in your MBBS level, right? Then they have asked you another exam question. Suppose you don't want to give steroids. So we are trying that we should not give steroids because it harms the eye in other ways. So this was asked in an exam about what is the Luminate program. So Luminate program, you will answer to find a non-steroidal treatment of uveitis. And for this, which is the drug which is studied under Luminate program? That was your exam question. Answer is voclosporin. So it's an immunomodulator like cyclosporin. Okay. So we will learn voclosporin. Right. So when I say topical steroids, we should also mention commonly given topical steroids. What will I prefer? So it will depend. If it's a severe uveitis, I have to start with prednisolone. I cannot take a chance because uveitis will harm the eye more otherwise, right? So we go for either we use prednisolone. Another few names that you should know is, one is difluprednate. Or if I want to go for a milder one, then I can give loteprednol. Right? So these are the steroids which are commonly given. Okay, lastly, one thing which needs a mention, if it's a chronic vision threatening anterior uveitis. So if it is a chronic vision threatening condition, right? In this case, we can give monoclonal antibodies. And very important names that, so what are the monoclonal? They are biological blockers. So monoclonal antibodies that that you have to know is, one is adalimumab. It has got good results, adalimumab. Right? So This is actually a TNF inhibitor, tumor necrosis factor inhibitor. Another one is infliximab. So these are some newer modalities which needs a mention, right? Apart from these monoclonal antibodies, let's put it as A. The second thing that you can notice, interferon alpha. Right? All these are used for your control of inflammation. Next we talk about is intermediate uveitis. We have discussed this. Intermediate uveitis is inflammation of the vitreous. We said peripheral retina along with pars plana. Right? So write down what is intermediate. This is a broad term which includes inflammation of vitreous. We will say vitreous, peripheral retina and pars plana. Right? Okay. Then we talk about that it is generally a chronic disease which is insidious onset. Right? Third point, write down no gender predilection. Right? Okay. Coming to etiology, why will it happen? So etiology of intermediate, again we can divide it into infectious causes, non-infectious and idiopathic. More than 70% of the cases are idiopathic. Okay, and this is what we call as pars planitis. This condition is what is pars planitis. Coming to non-infectious, we are going to remember two important ones. One is sarcoidosis and second you will learn is multiple sclerosis. The demyelinating disease, multiple sclerosis. Talking about infectious causes, the granulomatous inflammations like tuberculosis, leprosy, syphilis, and then of course also we are going to talk about toxocariasis. Right, so all these can be the causes of intermediate uveitis. Coming to clinical features. So this patient will not present with the same 5 features we have been talking about, the same 5 fingers, no. So no pain, generally no pain or redness. Main problem is blurring of vision. So there is blurring of vision. Later there can be diminution of vision. And thirdly, what the patient will complain of is floaters. Okay, so this is the presenting feature. On examination, what we get? Let's make a diagram here. So let's start thinking one by one. Make the diagram, all of you. Which is the main area which is being inflamed? Pars plana and back to that, that is peripheral retina and vitreous. So first thing that we will learn is inflammatory cells in this area. This is just behind the lens, so we call it retrolental flare. So first feature is retrolental flare. Then few KPs compared to anterior uveitis, the KPs are few, but they are there, few KPs. Then there can be inflammatory exudates floating in the vitreous. Okay, so this collection of inflammatory cells and exudates in the vitreous is what is called snowballs. So we see these collection of exudates as snowballs. We call it snowballs, right? And when this is an inflammatory fibrovascular plaque on the pars plana, generally seen inferiorly, this is called snow banking. This is what is snow banking. Okay, so this is nothing but a fibrovascular plaque, exudative plaque or deposition. This is what is called snow banking. All of you, exam question here. What is the pathognomic feature of pars planitis? We will answer snowbanking. Pathognomic feature of pars planitis is snowbanking. Anything else we want to mention? So there can be periphleboitis, right? So another feature can be, of course, inflammation of these are in the peripheral retina more, but these vessel inflammation. So inflammation of vein is what is periphleboitis, which is seen prominently. So these are the features easy to learn: retrolental flare, few KPs. Then we talked about snow walls, snow banking, and periphleboitis. Right. Now, investigation again, we already have seen what can be the non-infectious and infectious causes. So it becomes very simple. For investigation, again divide it as ocular and systemic. Ocular, you want to again see posteriorly, so ultrasound B scan. And for the associated CME, that it can cause cystoid macular edema, so we should go for either OCT or fluorescein angiography to check for that, right? For the primarily, mainly for this to exclude if there is any CME. Then talking about the systemic investigations, again especially for these infectious causes, we have to go for hemogram. And of course, we should go for the LFT, KFT, right? All the investigations that to exclude even tuberculosis, syphilis, right? Everything should be mentioned. So actually, it's, if you want to make your life simple, it will almost be same as anterior uveitis. Then for the sarcoidosis, we should go for the chest X-ray. Chest X-ray will be helpful in tuberculosis also. So generally, we do all this. We go for chest X-ray, blood sugar, right? All this. And of course, you have to also exclude the HIV. These are some of the VDRL. Yes, why not? You have to also mention VDRL. So all these investigations have to be done. This is intermediate. Now we talk about the treatment of intermediate uveitis. Very important point. So it is a self-limiting disease. We will start the indication of treatment. So in mild cases, it is self-limiting. Indication is only when vision goes less than 6/12. Then only I will start thinking of treatment. Now treatment can be by 4-step approach. When you say 4-step approach, we are talking about, we also call it step ladder approach. What do we do here? Which means when we will talk about step 2, it includes step 1 and step 2. When I am saying step 3, it is 1, 2 and 3. So this is what is step ladder approach. Step 1 would be, so topical. Should I go for topical? No. So this is what you have to understand, that the eye drops are not going to help in intermediate. It will not reach the pars plana. So how to give the local steroids? Local steroids, if not given topical, the next thing is you can go for, everybody remember subtenon? So there was sclera, episclera, tenon's capsule, conjunctiva. So we are giving injections subtenons. So we are going to give subtenon injection of triamcinolone acetonide. Or secondly, or for the local steroids, we may also go for intravitreal steroids. Okay, so intravitreal steroids, which can be, if I go for intravitreal triamcinolone acetonide, there is high IOP, which is a very big problem. It will raise the intraocular pressure. So you can, the other option can be slow release implants, which can be put inside the vitreous cavity. So the slow release, generally we have dexamethasone implants, right? So that will take care that there is no acute rise of intraocular pressure. For example, slow release intravitreal implants, you can write intravitreal implants of dexamethasone. Anyway, so the first step is always local steroid. If this doesn't work, what is then step 2? Step 2 is your systemic steroids. Now in systemic steroids, we are generally giving tapering doses of prednisolone. Right? Okay. Then we talk about step 3. Step 3, let us learn immunosuppressive therapy. Okay, so earlier we used to learn as cryotherapy, but now we will change it as immunosuppressive therapy. Immunosuppressive therapy, what you can give? Generally for children, we give methotrexate. Okay, you can give cyclosporine. And of course, some monoclonal antibodies that you should know is tocilizumab. Especially in children, we can give tocilizumab. And of course, we have talked about adalimumab. Just be familiar with the drugs. These are the drugs which can be used for intermediate uveitis. Right? What was the basis of cryo? We were putting the cryo, you are generally giving the cryo on the snow banking area. So corresponding to snow banking, right? If this was your snow banking area, the cryo was given corresponding to the snow banking area to damage its blood supply. So when the blood supply of this fibrovascular membrane was damaged, this was mainly the source of inflammation, and this worked. Got it? This I've made a rough picture. This was snowbank. Now, but it is seen that if we are doing it, there is high incidence of high risk of retinal detachment. So that is why we are trying to avoid this, and instead it is better to go for immunosuppressive therapy. Right. And after that, immunosuppressive therapy, what is that was step 3. Then we come to what is step 4. Step 4, if nothing is working, or suppose we are talking about if there is any vitreous hemorrhage or epiretinal membranes. So the step 4 is pars plana vitrectomy. Okay. So step 4 is going through pars plana and cutting the vitreous. Pars plana vitrectomy is step 4. So generally, this pars plana vitrectomy is helping you to manage the complications like retinal detachment, it may be needed, or there is a vitreous hemorrhage. But apart from that, suppose even then you can go for pars plana to just get rid of that retrolental flare and the cause of blurring of the vision. It decreases the bulk of inflammation as well, and the patient after PPV will start responding to steroids. Got it? So my message here is that apart from managing these problems of vitreous hemorrhage and other complications, the role of pars plana vitrectomy, I am repeating here, is to remove the cause of blurring of vision and decrease the bulk of inflammation by getting rid of all those inflammatory cells in the vitreous cavity. Right. So that was about your one treatment of intermediate. Now, another thing that we want to learn here, apart from this 4-step therapy or 4-step approach or step ladder approach, there is one more approach which has 5 steps. We call it Kaplan's modified Kaplan's approach. Just know this also. What is a modified Kaplan approach? So in modified Kaplan approach, we are using 5 steps. One is same, that is your local steroids, right? Then second is your systemic steroids. So details we have already done it. Then third will be immunosuppressive therapy. Again the same, the drugs that we have mentioned. And fourth step has been either cryo and laser. So it is not excluding cryo or laser totally. If needed, we are doing it. This is for peripheral retina at this time. Not exactly for this, but for the peripheral retina. And then fifth after this is your pars plana vitrectomy. Right? So this is your modified Kaplan's approach for managing intermediate uveitis. So that was about intermediate uveitis. And yes, in investigations, when I was talking about, just thinking of it, we should also add all the investigations related. The investigation that I was talking about, we should also add all these investigations that is related to multiple sclerosis. So we may need to go for your CT scan and MRI, brain and spinal cord, orbit, everything, right? So we have to explore all the investigations related to the multiple sclerosis should also be kept in mind, right? Again, nobody is going to ask you to list it. It's for your own understanding. So that was about intermediate. We next talk about is posterior uveitis. So let's talk about posterior uveitis. As the name suggests, we already know posterior means we are talking about the choroid. So posterior uveitis is not only choroiditis, but you have to understand all adjoining structures are involved. That is why we have mentioned we can call it retinochoroiditis or chorioretinitis. So what are the features you have to understand? It is not only choroiditis, but there is also retinitis. Okay. What else you see? The third thing you should know, the third component, there will also be retinal vasculitis. Right? So this vasculitis means we are talking about both artery and vein. Vein is what is called periphlebitis and artery is periarteritis. Got it? So, but this is more common, periphlebitis. Any retinal vasculitis, apart from how will it present? Apart from inflammatory exudate covering the blood vessel, we also get hemorrhage. So generally what we see when there is any blood vessel involvement, there will be perivascular cuffing. Cuffing means generally a covering with the inflammatory exudate. Okay. I make very simply, we are learning point wise in most simple way. Okay. And there will be hemorrhage. So whenever there is retinal involvement or choroid involvement and retinal vasculitis, this is what constitutes your posterior uveitis. Done. Now this was also called retinochoroiditis or chorioretinitis. Just let us be very, very clear about this, that we are here talking about posterior uveitis. Okay. So once we know this, then talking about your again investigations would be almost the same that you have learned for intermediate or posterior, right? So almost, or anterior uveitis. So it's almost the same. So I'm not going to repeat it again and again. That means I'm going to do OCT, ultrasound B scan, I'm going to do your fluorescein angiography if needed, right? And the systemic investigations to exclude the infectious cause as well as the non-infectious, which is again almost overlapping. Then we talk about is your treatment part. The treatment part again very simple, local steroids. So we will say local steroids exactly in the same way that you have learned for intermediate uveitis. I am writing same here to make you things simple for you. And if it doesn't work, we go for systemic steroids. Right? We may go for immunosuppressives, and very important, and treatment can be according to the etiological agent. If not steroids, we may be treating according to the etiological agent if it is involving the posterior segment or the choroid, right? So that was very simple way of understanding posterior uveitis. Now when I'm going to learn, when we are going to discuss one by one each of these conditions, it will become more clear to you all regarding the different types of uveitis. Okay, so I think it was fast and very simple regarding posterior uveitis. If you feel a little unsatisfied, we can write it also. If you talk about, and let's think together, if you say posterior uveitis, so many conditions we are going to read where there is a pan uveitis, even that includes posterior uveitis. So if you think about the etiology with me, think about the etiology with me. Infectious causes and non-infectious. Let's divide it as this, right? So if you talk about the infections, just a quick glance here. If you talk about the infectious causes, again we can think of, because tuberculosis causes a granulomatous panuveitis, so tuberculosis. Then we can talk about syphilis, right? Then of course your parasitic infections, that is toxocariasis, which was same as in intermediate, and also here toxoplasmosis, right? Or you can just think of it like this: parasitic, bacterial, viral. Viral में we will learn herpes simplex, herpes zoster, and your HIV. I think this is easier. So this way if you learn and think, you know these are the infectious causes. And non-infectious, very important of course, is sarcoidosis, which is also causing panuveitis. Where else you learn Vogt-Koyanagi-Harada syndrome, again a panuveitis. We are going to learn more in detail here. Then in sympathetic ophthalmitis, the panuveitis will also include the posterior uveitis. So it is including all three parts, right? And then of course this is not needed at your level, but multiple evanescent white dot syndrome. So what are the conditions? It's a non-infectious causes where there are white dots in the posterior uvea, that is in the choroid and the retina. Okay, this is a multiple evanescent white dot syndrome. Just know the name, nothing more than that. Okay. M-E, the white dot, it's mudes, right, as DS. Okay. So it is DS. So these are some of the causes, and of course in now common sense investigation has to be almost the same, and therefore and the treatment I have mentioned. So now till now what you have learned with me is what is uveitis, how to classify it etiologically, anatomically, and what are the details of anti-uveitis, how does it present, how do you investigate, how do you treat. Intermediate uveitis, how it presents, what are the causes, how do we investigate, how we treat. And lastly, the posterior uveitis. Done? So this is the base that you have formed about this chapter. Now comes the next very important part. We are going to take it in a little more detail about diseases associated with uveitis. We have already discussed it in theology, but few of them we have to take in detail. Okay, before that, let's see some slides we have missed. So let us see, what is this showing you? This is exactly what is this here. We discussed this. That is iris bombae. This is what you're seeing. Look at this. This is the bowing of the iris forward. This is the iris bombae. Can you see? Very shallow anterior chamber, almost touching the cornea here, which can later lead to peripheral anterior synechia. Correct? Okay, so what is next for us? Yeah, so in intermediate, these are the snowballs which are floating in the vitreous. It's a feature of intermediate uveitis. Floating in the vitreous cavity, it is a feature of intermediate uveitis. What is the next? This one? This is your, again, if you look here, it is deposition of this membrane, hazy. So much of haze in the vitreous is all due to the inflammation. And this is your snow banking. We are talking about snow banking. It's again a peripheral retina showing the same snow banking here. Okay, in this slide also. And a very, very clear depiction is out here. This is again snow banking. What is snow banking? We have learnt it as a fibrovascular plaque at the pars plana, right? Yeah. This is a pathognomic feature of intermediate uveitis. We learned this? Yeah. So these are few slides. We next one more. Look at this one. These are the choroiditis patches, which are seen as round yellow patches of choroiditis. So if you think about what you are getting in posterior uveitis, you can get these round yellow patches of choroiditis. There can be vitritis, there will be retinitis, and of course retinal vasculitis, as we said. And because of the retinal involvement, you will definitely going to get cystoid macular edema, right? So all these features are of posterior uveitis. Let's now give the heading diseases associated with uveitis. We are going to learn it very, very in a crisp manner and a point-wise manner. Okay, so I want all the attention here. So diseases associated with uveitis. Lot of questions in your exam from this part of the chapter as well. Okay, so what we will do, since we already know and have an idea about the features of anterior, intermediate and posterior, we know what is granulomatous, we know what is non-granulomatous. So suppose in any condition I just tell you, in this you get a non-granulomatous anterior uveitis. Automatically you know what are the features. If I tell you, okay, in this condition you get granulomatous panuveitis, again you know how it will present. So now we are going to just write in the boxes, learn point wise, make life simple. Okay, so first is your arthritis associated with uveitis. Arthritis associated with uveitis, we have already mentioned, all are, make a Q here please, HLA-B27 positive. All these arthritis majority are seronegative, means rheumatoid factor is absent. Okay. And what is the type of uveitis? Okay. The type of uveitis is, let's put a box here, non-granulomatous anterior uveitis. Please put the box. You will quickly revise when you look at the last moment. So this is non-calamitous anterior uveitis. Let's talk a little more here. Now this can be either presenting in an acute form, that is your acute anterior uveitis, or it could be just presenting as a chronic uveitis. So the example in chronic uveitis will be juvenile rheumatoid arthritis. What is now we are calling it as juvenile idiopathic arthritis. JIA is the new name. This is juvenile idiopathic arthritis. Right? So this condition, we generally divide it as three types. JRA can either be pauci-articular, or it could be, pauci means less, so less than 4 joints are involved. It could be polyarticular, where 4 or more than 4 joints are involved. And the third type is your systemic onset. Systemic onset is also called Still's disease. It is also called Still's disease. So systemic onset is mainly associated with systemic features. Now what we have to learn, when we say uveitis is associated with this condition, not all JRA is associated with uveitis. So this is your exam question. Which JRA is associated? Let us learn further. Of course, it's pauci-articular. Now pauci-articular is further divided as early or type 1 and type 2. The type 1 is early onset and type 2 is late onset. So it can be type 1, that is early onset, and type 2, this is late onset. Right? That it is the which type of pauci? It is early onset type 1 pauci. This one is associated with uveitis. Okay? Done? Clear? So how are we going to learn now? Which is associated? It is type 1, that is early onset, pauci-articular, seronegative JRA. This is the full description. If you will look in your exams questions, you will see this is how it is given. One of the options are described like this. Right? So please keep in mind these patients are generally females, girls, children, childhood disease, and what is juvenile? Oh, what is juvenile rheumatoid arthritis? Any arthritis within 16 years or less than 16 years of age. Okay, let's write this first. So juvenile idiopathic is less than 16 years of age. So your type 1 means these are it is happening in girls mainly. They are ANA positive, but again they are rheumatoid factor negative. Keep this in mind. These children are at increased risk of having associated uveitis. Now, when you talk about anterior uveitis, what did we learn together? It is presenting with all the 5 fingers, pain, redness, photophobia, etc. Now, pay attention. Though it is anterior uveitis, in these children of GIA, all these 5 fingers are absent. There's no pain, no redness, no photophobia, no blepharospasm. It's a silent smoldering inflammation. Eye is white, and therefore we also call this condition white uveitis because there is no redness. So you may understand it as it is nothing but atypical presentation of anterior uveitis, or it's an atypical anterior uveitis. Right? All the points clear? That was about your chronic. And when we talk about acute presentation, what are the examples? Ankylosing spondylitis, then Retter's syndrome, and psoriatic arthritis. You all know psoriasis is a skin disease. So psoriatic arthritis with multiple scaly lesions, right? So these are the conditions where you can get uveitis. All are HLA-B27 positive. Don't forget this. Now when I talk about Retter's, what is the triad of Retter's syndrome, all of you? I think we all know this. This is urethritis, it is arthritis, and conjunctivitis. This is the typical triad of Retter's. But apart from that, other ocular features, it will present as acute anterior uveitis. It can present as even scleritis, episcleritis, and let's not go too much in detail, you'll get confused. But all these parts, all these features, let's learn only, is also associated with uveitis and scleritis on episode. Okay, so once we know this, and generally reiters and the presentation is precipitated or triggered by some infection. So if you have to generally understand about reiters, it is triggered by, the problem is triggered by either Shigella or Salmonella infection. Okay, or sometimes Campylobacter. And lastly, learn chlamydia. Right? So all these infections may precipitate the features of reiters. Now this has not been asked yet. It was additional small point for you all. But yes, conjunctivitis, and it's also presenting as uveitis as well, along with the typical triad of urethritis, arthritis and conjunctivitis. This is enough for you. Okay, so that was about reiters. Again, you talk about ankylosing spondylitis. We all know ankylosing. Just be very, very clear about its systemic features. Okay. Ocular features, we will again learn about acute anterior uveitis is the main presentation, right? Apart from other features of it, can also, like reiters, present as scleritis and episcleritis. So because they are common, you can learn it. That was HLA B27 associated arthritis, first association. Come to the next one. The next association that we are going to learn is sarcoidosis. Okay, so everybody knows about sarcoidosis. It is a non-caseating, if you want to write, note down, it's a non-caseating granulomatous inflammation, and it is primarily involving the lungs. Now come to the ocular feature. It's a granulomatous inflammation, right? So if you talk about the ocular features of sarcoidosis, we'll make, whenever we are trying to enumerate ocular features, we make a diagram, isn't it? So you can start with writing, think outside. It starts with sarcoid nodules. So these are granulomatous nodules on sclera and episclera. Number 1. Right? Then if you remember your cornea chapter, it can lead to interstitial keratitis. And it can also be a cause of, we have learned this, band-shaped keratopathy because of hypercalcemia. It's always good to learn it together, right? And then after this, what else? What type of uveitis? Of course, it causes uveitis. Now all of you put it in the box. It's a granulomatous panuveitis. Simple. This is an exam question. We are going to put a Q here. It's a granulomatous panuveitis. Now, when you say panuveitis, we are saying all three parts are involved, right? Now, in the posterior uveitis, you learned with me how it presents. There can be periphlebitis. Now, very typical and important question. The periphlebitis, how will I know? Okay, this is the vein which is inflamed. How do I know this? Because of the cuffing. We learned, na? So, the inflammatory exudate is all covering this vein. Then I know, okay, this is inflamed. And this is what is called, or what do you call it? Venous sheathing. You learn it as venous sheathing. Okay, so venous sheathing is actually a feature of periphlebitis, right? Generally periphlebitis arthritis, but mainly we are talking about phlebitis. So if that vein has this inflammatory exudate all along, I know it is a periphlebitis, and there may be associated hemorrhage. Now in sarcoidosis, this is more seen as a segmental venous sheathing, okay? And this nodular or segmental periphlebitis is what is called candle wax dripping. So it's an exam question. Candle wax dripping is a feature of, so we will answer sarcoidosis. So what is happening here? There is a segmental or nodular periphlebitis or perivascular venous sheathings or periphlebitis, nodular periphlebitis. You can say. Let's have a look at candle wax drippings here. very thick venous sheathing. So have a look here. Can you see this? This is all segmental changes. This is the periphleboitis or perivascular cuffing, which is segmental. And this is how it is seen in an angiography, very, very clear. This is what is candle wax drippings, right? Again here, can you see this? This is candle wax drippings. And the perivascular sheathing is very thick also, right? Less like a wax, candle wax. So it's a candle wax drippings is mainly segmental, but it is candle wax means thick venous sheathing. So this is what is called, it's a feature of, so this is exam question. If you notice, I am writing Q. So it's a feature of sarcoidosis. They will just ask you straightforward question. 2-3 more terms that is important to learn for sarcoidosis. We already have seen how it presents. One is what is Lander's sign. Lander's sign is again it's a pan-uveitis, so there can be pre-retinal nodules. So note down pre-retinal. Exact position of pre-retinal means that is posterior hyaloid membrane of the vitreous and the retina. That space is pre-retinal. You are going to be more clear when you attend the retina chapter. So pre-retinal nodule is what is called Lander's sign. Just remember this. And then of course we have to be familiar. What is with these terms? Familiar with these terms? What is Hereford syndrome? All of you? Hereford syndrome is sarcoidosis with, along with that in sarcoidosis, it is the uveitis with parotid gland inflammation, right? So it is a uveoparotitis. This is seen in sarcoidosis. So uveitis with parotid gland inflammation is your featured in sarcoidosis is what is called Hereford syndrome. Again, this is a Q, right? So Lander's sign, Hereford syndrome, candle wax drippings, and it's a granulomatous pan-uveitis. These are all cues of sarcoidosis. One more term, though it has not been asked, but you should know what is Lofgren syndrome. Lofgren syndrome is again, syndrome means many features. So write down there is anterior uveitis. And along with that there is bilateral hilar lymphadenopathy, lungs are involved now, lymphadenopathy, and erythema nodosum. Erythema nodosum. Okay, these features are a part of Lofgren syndrome. Right, that was about sarcoidosis. So point wise, more important things that I have told, this is enough. Next association we will learn is Behçet's disease. Next heading, Behçet's disease. Do you all know what is Behçet's? Autoimmune disease. So it's actually a autoimmune vasculitis due to circulating immune complexes. So it's an obliterative, write down, it's an obliterative, it's an autoimmune disease and it's an obliterative vasculitis. Obliterative vasculitis due to circulating immune complexes. Circulating immune complexes. Right? So everybody remembers the features of Behçet's? That is your ulcers in the mouth, genital ulcers, positive skin test and eye involvement. Right? So we talk about eye involvement here, of course. So first of all, what is the ocular feature? Give the heading ocular feature. Do you know what is Behçet's also known as? First important thing, transient hypopyon syndrome. Transient hypopyon syndrome. Why do you call this? Because it presents as the eye is white and there is no redness, but there can be recurrent with recurrent hypopyon. Okay, so this type of presentation, and this hypopyon is not fixed, it is mobile because fibrin in this is less. So it's a mobile bilateral hypopyon. This is how it presents and it is recurrent. Therefore, we call it is recurrent. Therefore, you are calling it transient hypopyon syndrome. Okay. Once you know this, what is the type of uveitis and Behçet's? We will learn, put it in the box all of you. Primarily, it is a non-granulomatous pan-uveitis. Actually, it's a non-granulomatous pan-uveitis. And another question that has been asked, we have already discussed HLA association. So, it is HLA-B5 or HLA-B51. Suppose both are given, it has happened, then we choose B5, right? So, these are some important highlights of Behçet's disease that we have to keep in mind. And there can be spontaneous recovery even without treatment. So, generally it is a relapsing and remitting condition with a spontaneous recovery. Okay, keep in mind. That was about Behçet's. So, this is a slide which is showing you the usual venous sheathing or cuffing. So, this is not segmental as you saw in sarcoidosis, right? This could be one feature seen in Behçet's disease when it is involving the posterior uvea. That is vasculitis. And look here, this is the hypopyon. In this case, the eye is red, of course, and we are seeing all features of anterior uveitis, but you may find a presentation where eye is not that red and there is a recurrent hypopyon. Okay, so this is your hypopyon of Behçet's. Next condition, if we talk about, what about uveitis associated with inflammatory bowel disease? So when you just say uveitis in bowel disease, we will just know the names, not complicate our life with too many details. What has been asked is, it can be a feature of ulcerative colitis. I think I already mentioned this is more common than Crohn's disease. You all should be knowing the seismic details of each. And third, that is Whipple's disease. Okay, if you have forgotten, please revise all this. What are the seismic features? Right. So all these three may be associated with uveitis. Most common, it is the ulcerative colitis which is associated. That is one point to remember. They have asked you what is the most common ocular feature of ulcerative colitis. Then most commonly it presents as episcleritis. Please remember this. Okay, so there can be episcleritis which is more common. Then there can be scleritis, conjunctivitis, and of course acute anterior uveitis. So what is the type of uveitis? It is generally, so we are going to put it in the box and write it. This is enough. That is non-granular, it causes non-granulomatous anterior uveitis. Correct? Done? Okay. Acute anterior uveitis. Okay, there can be some difference among the sources sharing that uveitis is more common in ulcerative or in Crohn's. But according to the Kansky, we are going to learn ulcerative colitis, it is more common than in Crohn's. Nobody will anyway ask you to pick up, but suppose you are stuck with the different options, you should first answer ulcerative colitis. Right, we come to the next association. Next association after this is your renal disease. So, uveitis associated with renal disease. Now, I want you to learn only one line here. So, the renal disease mainly tubulointerstitial nephritis and uveitis, easy to learn, is called TINU. Okay? So, it is tubulointerstitial nephritis with uveitis. Again, this is bilateral non-granulomatous, just like your IBD, non-granulomatous anterior uveitis. Right? So, other inflammatory diseases or renal diseases can also present with pan-uveitis or different position, but what we will learn at this level, that this is about this disease and the type of uveitis here. Generally, commonly, let's pick up the common presentation. It is non-granulomatous anterior uveitis. Come to the next association. Number 5 only, just check it yourself. So, we come to the next association, which is again very important. Let us talk about is viral uveitis. So, viral uveitis, we are going to discuss very important first is HIV. Then we will be talking about herpes in detail, right? Yeah. So, we will first pick up your HIV. When you talk about HIV infection, this is a very, very important exam question. I will start with the question itself, that which is the most common ocular feature of HIV. If they ask you most common ocular feature, right? then please don't answer CMV retinitis. That is most common opportunist infection. Most common ocular feature we will answer HIV induced microangiopathy. Okay, so we will say it is HIV induced microangiopathy. And what are the features of this condition? What you see in the retina are hemorrhages. We will see microaneurysms. You all know permanent dilatation of capillaries aneurysm. When do you call it micro? When it is less than 100 microns. We call it microaneurysm. And you're going to learn this in diabetic retinopathy as well. And what is the third? Mainly, you have to know soft exudates. Now, what are soft exudates? So, hard exudates are what? They are leak lipids. And soft exudates, they are axonal debris. They are dead axons. Okay? That is what is called soft exudates. They are axonal debris. Now, there was one exam question where it was written most common ocular feature of HIV. All these three were given as options and one more. Now, then you have to pick up, of course, soft exudate if this is the situation. Okay, so this is one important question. What else HIV is doing and causing? Let's talk about that. If you start thinking from outside to in, what happens in the lids first? So, in the lids, if I talk about, so you can give the heading other ocular features. Of course, we make a diagram, but we will label this. First, talking about lids. Okay, so lids may, of course, everybody remembers Kaposi's sarcoma, right? Important, we have to learn this. There can be more incidence of blepharitis, which is inflammation of lid margin. Infection by molluscum contagiosum, you all know it's a viral disease. Molluscum, multiple molluscums are seen, right? That is typical of low immunity. Multiple molluscums, right? And features of zoster infection because it is more prone for these infections. This is the lid manifest features that you can see in the lids. Okay, then what about here? If we talk about your conjunctiva, again in the conjunctiva we have to answer Kaposi sarcoma. Then squamous cell carcinoma is also more common. Squamous cell carcinoma. Next we talk about cornea. Cornea manifestations. Let us learn the infection by EZ. Infection by simplex virus, more keratitis, also all these viral keratitis you are getting. Right? What else? You can also get fungal keratitis more here in the cornea, and there can be keratoconjunctivitis sicca. I just want you to read it and there's no need to mug it up, just have an idea. What you have to learn, I've started with that. That was your exam question. I'll tell you next what you have to learn. After this, another important thing is, of course, uveitis. It can present mainly as an anterior uveitis here. Then posterior microangiopathy, of course, which is more common. That means it is involving so it's more like a pan-uveal involvement. Okay. So, microangiopathy, you can label it out here. This microangiopathy is generally disappearing by itself. Okay, it's generally asymptomatic and it disappears by itself. It is also associated with decreased CD4 count or T cell count. That is very important. It is associated with decreased CD4 count. So, among what all you have written, most common is, this is most common, right? Ocular feature of HIV. Another thing is, what does it cause in the orbit? HIV infections in the orbit, you should also know, it can lead to orbital cellulitis, right? Especially with a fungal. And it can lead to B cell lymphoma. This was just to complete the list here. Now talking about What is the most common opportunist infection? That has been your next important question. So let us give the heading, what are the different opportunist infections of HIV? I'm talking mainly ocular here. So first, which is most common, Q lagao, this is your CMV retinitis. CMV retinitis. Everybody remembers how does a CMV retinitis present? Let's see. Have a look. These are the cotton wool spots as a part of microangiopathy in HIV. This is the microangiopathy of HIV. And what we can see here are the cotton wool spots. I can even see some hemorrhages here. This one, blot hemorrhages. This is your Kaposi sarcoma. Again, conjunctival Kaposi sarcoma of HIV. And this is what I am talking about. If you look here, this mottled appearance, which is also called pizza pie appearance, this is CMV retinitis. So few points here in CMV, I'll write it here only. It is most common opportunist infection in HIV, number one. So because of the mottled, even they have specified which pizza, so it's a margherita pizza appearance. So why you are getting it? It is mainly retinitis. These are the hemorrhages. So another name of this condition is sauce and cheese retinopathy. This is a feature of CMV retinitis. So sauce is hemorrhage, cheese is the necrosis due to retinitis that you see due to cytomegalovirus. Again, this is a typical sauce and cheese. It is involving, and if you see here, it is generally spreading along the blood vessel. That is why it is called as a brush fire appearance. This is spreading along the blood vessels peripherally in the peripheral retina. So brush fire appearance. So this is the hemorrhage. This is the necrosis. This is what is sauce and cheese retinopathy. This is what is sauce and cheese retinopathy of CMV. This opportunist infection will happen when there is a low CD4 count. Okay, strongly associated with low CD4 count. Very important. And apart from what you saw as a sauce and cheese retinopathy and the retinal manifestation, what are the other features that you see is you may get vitritis, you're getting arthritis and even optic neuritis. Okay, so these can be the presentation of CMV. What else? What is the next opportunist infection? There can be pneumocystis carinii choroiditis due to pneumocystis carinii, right? Or other fungal like cryptococcal. So if I talk about cryptococcal choroiditis. So this one is fungal. What can be the other viral opportunist? If we just classify this way, easy to learn. For viral, of course, along with CMV, we will say other opportunists will be herpes zoster, which causes acute retinal necrosis. And it could also be herpes simplex virus infection. And the next is your protozoal infection. And the protozoal infection, of course, is toxoplasmosis. This also causes, we are going to learn about toxoplasmosis, causes choroiditis. These are all other opportunist infections. Right. So once we know as we have just learned that when we know the etiological agent, you have to treat accordingly. So here the treatment will be antiretroviral therapy. Isn't it? Now there's one very important exam question for you all, that a patient is on heart therapy. This is highly active antiretroviral therapy. What is the most common ocular side effect of heart therapy? So this is interesting. Understand, when you are giving a heart therapy, the immunity improves. And when the immunity improves, again there will be inflammation. So most common side effect is immune recovery uveitis. This again it is uveitis. This time we call it IRU, which stands for immune recovery uveitis. Correct. So immune recovery uveitis is which type? This is again debatable. It is actually involving all the three parts of your uvea. But if all are given in the option, we are first saying primarily it is a vitritis. So intermediate uveitis is actually most important component. Of course, it will also cause anterior uveitis and posterior uveitis. But if all three are given, what did I say? You are going to answer intermediate or posterior uveitis or vitritis. Vitritis is the most prominent feature of immune recovery uveitis, isn't it? And of course, if there is a viral infection after this antiretroviral therapy, what next I can give? We may need to give intravitreal ganciclovir for the CMV. So ganciclovir implant. Intravitreal implants can be put. Right? And if it is immune recovery uveitis, for immune recovery uveitis, the treatment is steroids. This is only when we give steroids, otherwise not. You can also give oral valcyclovir or ganciclovir for the viral infections. First write it here, intravitreal or oral. Okay? So these are the points we have to know about the HIV infection and the viral uveitis. So what was the next main point is about herpes infection, isn't it? Talking about the other viral manifestations, we will learn about acute retinal necrosis. So through herpes, one is acute retinal necrosis. Right? Generally caused by herpes zoster, varicella zoster, I mean to say. So varicella zoster virus is a causative for adults, and in young people this can even be caused by herpes simplex virus. What does it cause? Put it in the box. It's generally a pan-uveitis. It's a pan-uveitis with retinal necrosis, peripheral retinal necrosis. This much just is enough. And how will you manage it? We will give antivirals. So you can give acyclovir or other antivirals, oral acyclovir and oral valcyclovir. In severe cases, steroids, but always under antiviral cover, never without it. Okay, so steroids are always given, and yes, we can also give intravitreal ganciclovir. Let's not forget, another is intravitreal ganciclovir is another option. Cyclovir. It is CY or CI, both are correct, right? And lastly, we will say systemic steroids under cover may sometimes be needed, but under antiviral cover. But don't give it as a routine, you are only giving it as in severe cases. What is the other form of the herpes infection that we have to know is anterior uveitis. Anterior uveitis generally, it can be caused by both herpes simplex virus or varicella zoster virus. Now the simplex keratitis, what are the typical features? I think herpes uveitis, we have learned this, is sectoral iris atrophy. Make the diagram all of you. Sectoral iris atrophy. Let's not forget, and the KPs, just like Fuchs heterochromic, can be stellate KPs. And yes, we may get hyphema. So this is not the only feature, these are not the only features. We are saying apart from the usual features of anterior uveitis, these are some typical features which we have to keep in mind. So it presents as anterior uveitis as well. And again, anterior uveitis is treated with topical steroids, but again we have to keep in mind that this is under antiviral cover, right? So treatment would be, of course, topical steroids and cycloplegics. But along with that, I will also give oral antivirals. Right? So this was about viral uveitis. Clear है? क्या क्या पढ़ा था? What all we read is HIV. We talked about herpes, which can manifest as acute retinal necrosis or as commonly as anterior uveitis. Okay. Then we talk about bacterial uveitis. When you say bacterial uveitis, we have to learn three main things here: tuberculosis, syphilis, leprosy. Write down tuberculosis, syphilis, leprosy. First we take tuberculosis. Let us learn it causes, in the box all of you, granulomatous panuveitis. It causes granulomatous panuveitis. They have asked you the questions in two ways. One way is, what is the most common ocular feature of tuberculosis? And secondly, they have asked you, which is the most common allergic manifestation of tuberculosis? So if they ask you most common ocular feature of tuberculosis, your answer should be uveitis. Okay, it is uveitis. You know what type of uveitis? You have learnt it. In your options, it was given Cope's nodule, so that was the correct option. Apart from other options, but you have to not only remember this, it can be all the features of uveitis. And most common allergic manifestation, we have learnt in conjunctiva chapter, it is flectanular keratoconjunctivitis. Flectanular keratoconjunctivitis. Right? Okay. So next we talk about, so once for all, we have already learned the features of anterior, intermediate and posterior, and now we are just fitting in and learning point wise. I think this is simpler. Yeah, we come to syphilis. How does syphilis present? It's not a pan, but it is generally either anterior uveitis or it may present as posterior uveitis. Anterior or posterior uveitis, which may be either granulomatous or non-granulomatous. Okay, so any of the presentation is possible, right? Now, what are typical things? Of course, if anterior uveitis, you know what are the features. What else we will learn is one important finding, which is typical of syphilis, is iris roseola. Now, what is this iris roseola? Iris roseola are nothing but dilated capillaries which develop into nodules. Write down dilated capillaries which develop into nodules. So this is one point. Talking about, okay, have a look. See, this is iris roseola, right? So this is a feature of syphilis. This is the iris roseola. And when you say posterior uveitis, do we all remember? We learnt in our early chapters as well. Salt and pepper fundus. So it will cause chorioretinitis, and this chorioretinitis in syphilis is seen as salt and pepper fundus. Let's not forget this. Right? If it is diffuse, it is salt and pepper fundus. It can be localized choroiditis also, but if it is diffuse, it's a salt and pepper fundus. Okay, so that was about your syphilis. These are the important points. That's it. Next was leprosy. Okay, one more thing I would add here. With syphilis, it is generally the secondary syphilis, okay, where this infection and uveitis mainly takes place during secondary infection or secondary syphilis. Then we talk about, next is your leprosy. So what do we see in the leprosy? First of all, very important point, it is mainly the lepromatous leprosy, where you will get the ocular features. In lepromatous infection, it is due to direct infection, isn't it? Direct bacterial invasion. All these ocular features are due to direct bacterial invasion. What does it cause? Again, point wise only. Make a box, all of you. It will cause a chronic granulomatous anterior uveitis. Can we learn this? Chronic granulomatous anterior uveitis. Okay. Very important feature here are iris pearls. This term should be clear to you. What are iris pearls? Iris pearls are pathognomic of this anterior uveitis. It is pathognomic feature of leprosy. Right? So, it is nothing but, this is a location where the bacteria are all. So, it consists of mainly bacteria. That's what I want to say. Let's have a look. See, these are what are iris pearls of lepromatous leprosy. Okay, these are all collection of bacteria. So, what else you have learned in leprosy? We should remember this. Let's make a diagram here. Thickened corneal nerves. Did we learn this? Yes. And we also learned about decreased corneal sensation. Decreased corneal sensation. And then of course granulomatous anterior uveitis, which is chronic anterior uveitis. So all the features plus these iris pearls which are pathognomic, right? So these iris pearls are typically less than 0.5 mm in diameter. You may also get iris atrophy. And similarly, we can get retinal pearls as well on the retina. Okay? Right? And if we think outside to in, let's not miss to also mention scleritis and episcleritis. So it can also lead to scleritis and episcleritis. So these are the features of leprosy infection, the ocular features. Now talking about leprosy, what is the treatment? Of course, you will give dapsone, right? So systemic treatment should be given. And apart from that, for the anterior uveitis, we will give as usual topical steroids. And systemic treatment, we can give either dapsone or rifampicin. Okay. Whereas when we talk about syphilis, we have to give penicillin. Okay, don't forget that. For syphilis, I think we have forgotten to mention. So syphilis, iris roseola, wherever you have written, you will get. We have to treat it with, the systemic part has to be treated with penicillin. Right, so this was about the bacterial uveitis. We have to keep these points in mind. Leprosy has a long list of ocular features. We have enumerated a few, and I also remember we should also mention madarosis. If you remember, that's one of the causes of the loss of lateral 1/3 of the eyebrows is your leprosy. And second was myxedema, right? And then leprosy can also cause seventh nerve palsy, which can lead to leg of thalamus. Yeah, so many features of leprosy in eye. Okay, so our next heading would be your parasitic uveitis. What do we need to learn in parasitic uveitis? Very important and most important for all of us is toxoplasmosis. Toxoplasmosis, you all know what is the definitive host of this parasite? It is cat. Okay, so definitive host is cat and it is the intermediate host is your humans. So we have to be very careful. You get infection from cats and the fecal matter of the cats. Anyway, so this Toxoplasma gondii, which is causing this infection in eye, what are the ocular feature? Point wise only. We will learn it can lead to either granulomatous or non-granulomatous. Let's put it in the box. Primarily, it is posterior uveitis. So this is typical about this, that is a posterior uveitis which spills in as anterior uveitis. Okay, so primarily it is posterior uveitis. So that means both are possible and it can either be granulomatous or non-granulomatous. You want to write this way, you can write like this. So presentation can be granulomatous or non-granulomatous, anterior and posterior. All the combinations are possible, but primarily it is posterior and anterior uveitis is occurring as a spillover. Just remember this here. We come to what are the points they will ask you. We'll make a diagram here. As a part of posterior uveitis, what is very typical about toxoplasmosis is intense vitritis. Vitritis is so intense that when we are looking through it, it feels we are looking through a fog. Okay, so the lesions that we look through a fog due to intense vitritis, the whole clinical picture is called headlight in fog appearance. So this is one question. Headlight in fog appearance is a feature of, we answer, toxoplasmosis. So headlight in fog appearance. Okay, and when it will, this is happening in active inflammation. On healing, so it is another important point, it mainly involves the macular area more, so it will definitely affect the vision. And on healing, there are punched out lesions. I'll show you this, just note down. Punched out lesions with pigmented margins. With pigmented margins. Okay, or pigmented punched out lesions. That is equally correct. So these are the two main points we are going to remember about toxoplasmosis. Let's have a look. So this is what is headlight in fog. Can you see the choroiditis patches, right? White inflammatory, retinal inflammatory areas. These are all looking as if so hazy. Why are you seeing the retina choroidal findings so hazy? This is all because of intense vitritis. So this is what is headlight in fog appearance. Intense vitritis, this is headlight in fog appearance. Look at this one. So this is your headlight in fog appearance. And what is this? This is the healed lesion. Can you see this? Punched out pigmented lesions. Particularly in the macular area, these punched out pigmented lesions is what we are saying is typical of toxoplasmosis. Talking about the treatment part, of course, as you treat toxoplasmosis anyway, you will have to start the treatment accordingly. So one is your classic or triple therapy that you give for treatment of toxoplasmosis. What is that? What are the three drugs? Write down, it is pyrimethamine with sulfadiazine and clindamycin. This is what is triple therapy. And under the cover of this, we can give steroids under cover of these drugs. And we can also, one option is intravitreal therapy. Okay, so intravitreal, if I have to give, I can give intravitreal clindamycin with dexamethasone. So we can give intravitreal clindamycin. Just have an idea, we are giving the usual drugs that we use to treat toxoplasmosis. No details will be asked, right? Just note it down for yourself. So these are some of the options. What are the other parasitic infections that we should at least know? The second one, note down, is onchocerciasis. Now this is also, what are the things they have asked you? You all know this is a nematode. So this infection is caused by Onchocerca volvulus, which is a nematode, right? It is also called river blindness. You should know why it is called river blindness. Why it is called river blindness? Because the vector through which it is spreading is near the river waters, right? That is the black fly, right? So because of that, we call it river blindness. So this, because the vector is a black fly, that is Simulium black fly. So this disease is generally not very common thing in India. Of course, it's a disease of South Africa and not a disease of India. Just keep this in mind. So this is the vector. What is it causing in the eye? So onchocerciasis or river blindness is causing, in the box all of you, non-granulomatous, either anterior or posterior uveitis. Either anterior uveitis or posterior uveitis. It's a non-granulomatous. So you already know what are the features. Okay. Also, what is the cause of blindness in this condition? This was one of the included in the program Vision 2020. We are now in 2022, so we don't talk about this WHO program. But one of the diseases in Vision 2020 was onchocerciasis. It's a cause of blindness. And the cause of blindness in this disease generally is, note down please, sclerosing keratitis. Right? So, it can lead to sclerosing means, when you say sclerosing keratitis, what does this mean? The cornea is becoming opaque like sclera. So, that is what is called sclerosing keratitis. So, this is the main cause of blindness in onchocerciasis. Right? It was a part of Vision 2020 program. Okay. What is the treatment of choice? If they ask you, you will answer. Here we are going to treat it with ivermectin. Ideal drug is ivermectin. But ivermectin can only kill the microfilaria, not the adult form. Okay. So, but you have to say the treatment of choice, this is the drug we have. Along with that, you can give prophylactic steroids to control inflammation. And for the adult, the drug is IV suramine. This is effective against the adult worm. Okay? Right. So we'll remember these two important points. What is the next parasitic infection which needs mention? Cysticercosis. Cysticercosis is caused by Cysticercosis cellulose, which is a larva of Taenia solium. So you all remember better than even me. This cysticercosis calcifies. The cyst will calcify, and therefore it is one of the cause of intraocular calcifications. This is something to be kept in mind. Right? So not much details are needed. Just let us understand that what it can lead to. We'll make a diagram here. So generally you know na, it mainly affects the eyes, muscles and brain. Right? These are the three places where you will find this worm. Right? So when you talk about eye involvement, it can lead to conjunctival cysts. Then the cysts can be seen in the aqueous humor, that is in the anterior chamber. They can be free floating. Cysts can be found here as well. Then intense vitritis, it causes vitritis which is very, very intense. So intense vitritis, right? And of course, we can see these cysts and larva is also seen in subretinal space. So just diagram, peep in, and you will know what we are talking about. Just remember, it calcifies and can be a cause of intraocular calcification. This is an important point. Again, if you are giving the treatment part, and of course, yes, this can also be seen in the extraocular muscles, very important, in extraocular muscles. We find cysts in the extraocular muscles. Most common muscle where you can find is superior rectus. Note down please, in superior rectus is the most common muscle where you find the cysticercosis cyst. If it is so, what will it manifest as? Pain, swelling, and of course you will see some restriction of movements, isn't it? Swelling, pain and restriction of movement. Yeah, so that was about cysticercosis. Of course, apart from albendazole, this has to be given along with steroids to control the inflammation, right? So treatment would be both systemic steroids, albendazole under the steroid cover, okay? So you give systemic steroids to control inflammation. You know, if you only give albendazole, these inflammations can even cause death if the cyst is in the brain, isn't it? So we just give, and similar reaction can happen in onchocerciasis, which is called Mazotes reaction. Okay, you want to write? So in Mazotes reaction, what is happening? That again similar thing, a severe inflammation leading to a life-threatening. This becomes a life-threatening complication. So systemic steroids for inflammation and albendazole is only given with steroid cover, and you may need to surgically remove the cyst. Okay, surgical removal of cyst. Right. That was about your cysticercosis. And what about toxocariasis? The last name, toxocariasis. You have to remember two main points here, which they can ask. One, this is again one most common parasitic, ocular parasitic infection in children. First important point, most common parasitic infection of children. This is important, okay? This has been asked. And of course, next thing they have been asked that you have to keep in mind is, this is also, we learn it as a differential diagnosis of leukocoria for children. What is leukocoria? White eye reflex. Leuko is white, coria is pupil. So, white eye reflex. So, you know, na, Toxocara canis. This is the infection by Toxocara canis. You should know this, right? That means roundworms of dogs. This is Toxocara canis. This is the roundworms of dogs. This is also going to cause both anterior uveitis and posterior uveitis, that is chorioretinitis. So it is causing both anterior uveitis and also posterior uveitis, that is chorioretinitis. Mainly chorioretinitis. And very important, so it also leads to chronic, and it is causing chronic endophthalmitis, and because of this there is leukocoria and the child presents with leukocoria and strabismus, right? You can note it like this also. If you make a diagram, it becomes easier to learn. You can write here anterior uveitis, then chronic endophthalmitis. So as a part of it, there will be vitritis also, and here you get chorioretinitis, right? So it's like almost a pan uveitis. So, main important two questions, just keep remembering for toxocariasis, nothing else has been asked. Okay, so much information about bacterial, viral and parasitic infections which can lead to uveitis. So, this is onchocerciasis, these are the skin lesions, and here you can see is sclerosing keratitis in onchocerciasis. Okay, so this is the sclerosing keratitis of onchocerciasis. See, this is the worm which is seen subconjunctivally. We are looking at Onchocerca volvulus. I know it looks frightening, right? Anyways, then we come to the next one. This is the conjunctival cyst of cysticercosis. So this is the cysticercosis cyst. See, this is excised. This is how it looks. What is our next heading? VKH syndrome. This is also very important for exams. VKH stands by the name of three scientists, that is your Vogt, Koyanagi, Harada. Vogt, Koyanagi and Harada are three scientists at three different places who had diagnosed this condition. So, Vogt, Koyanagi, Harada syndrome or VKH syndrome. Now, what is this VKH syndrome? So, this is nothing but an idiopathic and autoimmune disease, okay? And the autoimmunity is towards the melanin containing tissues. Okay, so autoimmune disease where inflammation of the melanocyte containing tissues. Right? Okay. So idiopathic autoimmune inflammation of melanocyte containing tissues. Right. So primarily it will involve the eye mainly. We are talking about uvea. Uveal tissue is the melanocyte containing tissue in the eye. Then it involves the ear and it involves the meninges. Right. So what are the features? It is mainly a granulomatous panuveitis. Okay, it's a granulomatous panuveitis with what are other seismic features that we have to learn? First is encephalitis. There can be vestibular dysfunction. Then tinnitus, alopecia, vitiligo, and poliosis. What is poliosis? Graying of eyelashes. So these are the other features that you will see in these patients. So we can actually learn that this Uveitis syndrome has 4 stages. The disease has 4 stages. First phase or first stage is your prodromal phase. When we say prodromal phase, this is a phase where there are neurological and auditory symptoms. Right? So there will be, it starts with neurological and auditory manifestations. Then we talk about acute uveitis phase. Next phase, acute uveitis phase, where it will present with, as we just learned, granulomatous pan uveitis. As a part of pan uveitis, we have to keep in mind that it can later lead to exudative retinal detachment. It's a prominent feature, much more common than any other condition that we will be comparing with sympathetic ophthalmitis. So, please remember, it is causing granulomatous, both anterior uveitis also and posterior uveitis, and a prominent thing in posterior uveitis is later it leads to exudative retinal detachment. So, this is a very important point, so we will just note it like this. Then what is the third phase? The third phase is your convalescent phase. Convalescent phase is mainly, we are talking about, there is depigmentations. So, when there are depigmentations or depigmentation phase, eye point of view, what we have to learn? Of course, there is vitiligo, we are just seeing what is poliosis, is graying of eyelashes. Similarly, you have to know that when there is a depigmentation which is perilimbal, that is called Segura sign. I'll just show you the slide. So, Segura sign, just remember this, is perilimbal depigmentation. And when this happens in the choroid, now what happens when there is a depigmentation process in the choroid, this choroidal depigmentation is seen as sunset fundus. Okay, let us have a look at it. Just let me complete the phases. So this is your sunset fundus. And what is the fourth one? This is chronic recurrent phase. So in the chronic recurrent phase, it mainly manifests not as posterior, only as anterior uveitis. Generally, it will reoccur as anterior uveitis. Okay. Then let's have a look at the slides here. Okay, so what are you looking here? This is your poliosis. You're looking at poliosis, some depigmentation and vitiligo here, and even eyebrows are involved, right? Look at this. This is the depigmentation in the choroid. Okay, because of the depigmentation in the choroid, it looks like a, this picture is what is called sunset fundus. Okay, so what is sunset fundus? It is nothing but depigmentation. Again, this is your sunset glow fundus due to depigmentation. And look at this one. This is the perilimbal depigmentation here. This is called Segura sign. This is your Segura sign. Okay, so these are the findings of Vogt Koyanagi Harada. So there is another question apart from Segura sign and sunset fundus. They have all asked you about which uveitis is associated with encephalitis, something like this. So if this is the question, I think we all are very clear. We are talking about VKH syndrome. Our answer should be VKH syndrome. Now, if it's an autoimmune disease, what do you think? What should be the treatment? Again, it comes to steroid. We start with IV methylprednisolone and then we go to the oral prednisolone, right? And then shift to oral steroids. So after giving some bolus dose, 3 to 5 days, we go to the oral steroids. So mainstay is this only. And in steroid resistant cases, we will go for monoclonal immunosuppressive. So if the patient is steroid resistant, then the biological blocker that we are commonly giving is infliximab. Okay, right. So that was about your VKH syndrome. We next talk about, lastly, we have to discuss very important topic, and that is sympathetic ophthalmitis. So give the heading sympathetic ophthalmitis. So when you say sympathetic ophthalmitis, this is injury in one eye is causing uveitis in the other eye. That is why it is called sympathetic. The other eye has not been injured, but still there is uveitis there. Okay, got it? So which injury? That is the first question. It is always a perforating injury, especially in which there is iris prolapse. Okay. This is going to lead to uveitis, of course, will happen in the eye which is injured, but this is causing uveitis of other eye as well, and this uveitis of the other eye is what is called sympathetic ophthalmitis. So this other eye is called what? It is called sympathizing eye. And the eye which is traumatized is what is called exciting eye. So common sense why it is happening. So this is due to autoimmune reaction towards uveal tissue. So there has to be some autoimmune reaction towards uveal tissue that affects even the other eye. So the antigen, particularly the antigen, these are all melanin containing tissues. The antigen that is responsible, if they ask you, they have never asked you this, but if they ask you, one name that we will say is retinal S antigen. So it is not only in retina though, so don't get confused. We'll just say retinal S antigen. Next they will ask you is, okay, today is the injury, when will we expect a sympathetic ophthalmitis in the other eye? So it has been seen how much time it takes for any autoimmunity to develop, at least 2 weeks. So it will never happen before 2 weeks. This is another exam question, see I have put a Q there. So never before 2 weeks, very important topic. Maximum chances are that it manifests after 2 weeks, from 2 weeks to 3 months time. Majority of the cases, the maximum chances in this duration. And sometimes it can be as long as after years. But yes, this is majority of the patients will manifest within this time period. What is causing? What type of uveitis? This is the next question in the box, all of you. It's a granulomatous panuveitis. So it's a granulomatous panuveitis. So if it's a panuveitis, we get nodules. If it is granulomatous, we get nodules, right? So these granulomas are typically, where are these nodules? I'm not talking about iris nodules here. These nodules, let's make the diagram. This is your, suppose the retina with the retinal pigment epithelium being the outermost layer. Outside the retina, this is your choroid, correct? Make this choroid. And between the retina and choroid is a membrane, and this is what is called innermost layer of the choroid as Bruch's membrane. This is the Bruch's membrane. Now, we see these nodules between the retinal pigment epithelium and the Bruch's membrane. These granulomas are what are called Dehlen-Fuchs nodules. This is again a very important repeated question, Dehlen-Fuchs nodules. It's a feature of, you will answer, primarily we will answer sympathetic ophthalmitis. Okay. Then what about the term sunset glow fundus? Please, we are going to talk about sunset glow fundus. First priority VKS syndrome that I just discussed, but sometimes due to chorioretinal scarring, we may get this type of picture in sympathetic ophthalmitis as well. So just know it that it is an overlapping term for both, but we primarily use it for VKH syndrome. That is very important, right? Okay. So these are some of the very important questions and points they will ask you. Then they have asked you another question. What is the first sign of sympathetic ophthalmitis? So what is the first sign? It starts as retrolental flare. So first sign you will say retrolental flare. First sign is retrolental flare. Do you realize this? If it is starting from behind the lens, this is mainly the ciliary body area, correct? All of you? And what is the role of ciliary muscles? Accommodation. So what should be the first problem the patient will be complaining? So next question, what is the first symptom? Oh, first sign was what? Retrolental flare. My question is, what is the first symptom? First symptom now you will answer is difficulty in near vision or decreased accommodation. So we are going to answer difficulty in near vision or decreased accommodation. Got it? These are actually double Qs. They are not Qs, they are repeated questions. Another question they've asked you, which is a dangerous area of eye? This term has been used by Parson himself. Dangerous area of eye. So if they ask you dangerous area of eye, your answer is ciliary body. Why is ciliary body the dangerous area? Because any trauma to the ciliary body is a big risk of sympathetic ophthalmitis. That is why we call it as a dangerous area of the eye. Okay, so how to manage? Right? How will you manage? Of course, we start with, if it is anterior uveitis, you are giving topical steroids, but very important, we have to give high dose of oral steroids because we want to prevent this autoimmune reaction in the other eye. So if you have a patient with any injury, perforating injury in one eye, what you have to do is give high dose of oral steroids in order to prevent the sympathetic ophthalmitis. If there is anterior uveitis, I will also treat it with topical steroids, in this patient. Okay, this is how I am managing. What else I can do? I may also start with, if there is a high risk, early immunosuppressive therapy to save the other eye. Okay. Then there is another example. Now suppose the eye which is traumatized is irreparable. I have to remove the eye. Which surgery is recommended? We will never do evisceration. What do you do in evisceration? You are cutting the cornea, scooping out everything, right? And then stitching the remaining sclera. So when you are scooping, you will leave the uveal tissue. Now the autoimmune reaction will happen and the other eye cannot be saved. Some uveal tissue can still be left. Therefore, if we need, write it down, to remove the traumatized eye, to remove the injured eye with the injury, then always do enucleation. We are going to talk in detail about these surgeries in the orbit chapter. But know it here also, enucleation is when I am removing the whole eyeball along with maximum part of optic nerve. After freeing all the muscle attachments, I cut the muscle attachment, I remove the whole eyeball with maximum part of the optic nerve. So this is what is always doing enucleation. Why? So that I am assured that there is no autoimmune reaction towards the remaining uveal tissue. Okay, so this is a very important point. We are going to pay attention to this. Right, all of you? So that was all about sympathetic ophthalmitis. So these are so many questions, if you realize, I have discussed, and it should be very, very clear to you. Right? Okay. Then, so look at this one. These are the Dalen-Fuchs nodules that we are talking about, granulomas and sympathetic ophthalmitis. The arrows are already there, right? So talking about, give the heading, Fuchs heterochromic cyclitis. As the name suggests, when you say heterochromic, right? So it is difference of iris color, isn't it? Heterochromia iridis. That means this is a unilateral condition where there is difference of iris color. And what is important to know, that it is the involved eye which is hypochromic. Okay, so the eye with uveitis, involved eye is, let's note down, involved eye is hypochromic. And what did we learn for arthritis associated with uveitis, especially for JRA when we were talking about? It is atypical anterior, right? Similarly, another form of atypical anterior uveitis in the whole list that you have learned with me is Fuchs heterochromic cyclitis, which means there is anterior uveitis, but there is no pain, no redness, no photophobia, no blepharospasm, right? This is what we mean. And of course, it's not only anterior, it may turn into posterior, it may involve the posterior uvea as well. So we will learn here, it is generally considered an atypical, presentation is atypical anterior uveitis. And what is the type of uveitis? All of you put it in the box. It is a non-granulomatous anterior, okay? Non-granulomatous anterior uveitis. So it's a chronic non-granulomatous anterior, and it may involve the posterior uvea also, leading to posterior uveitis. But primarily at your level, we will talk about anterior uveitis. right? So what do you get on examination? As I just said, patient will not have any pain, redness, photophobia. It's more of an atypical presentation. What I am going to get on examination? Let's make a diagram here. First of all, talking about KPs. So we will learn that there are stellate KPs, star-shaped KPs with feathery ends. Okay. So first point is stellate KPs. Then next, of course, we have learned about heterochromia iridis. So HI. What next? Diffuse iris atrophy, which is a very important point. There is diffuse iris atrophy. What happens due to this? There will be exposed blood vessels. Okay, so exposed blood, these are not new blood vessels, but they are mainly exposed blood vessels on the iris and on the angle, right? Then what are the other points? Very important, it will complicate as posterior subcapsular cataract. Okay, it's a common finding, PSC. And yes, let me continue with this. Because of diffuse iris atrophy, we will remember no posterior synechia. So note down, no posterior synechia. Right? So now we remember all the points here. Another thing, you can get some iris crystals. These are called Russell bodies. Just know the name, not important much. Just know the name. These are iris crystals, Russell bodies in Fuchs heterochromic cyclitis. Now these exposed blood vessels which are on the iris and on the angle, what happens? Because of this, when I am doing a paracentesis, that is removing the aqueous from one angle or one quadrant, what happens? You see bleeding on the opposite angle. This is what is called Amsler's sign. Okay, what did I say? I'll repeat. Paracentesis from one side leading to bleeding is Amsler's sign. This is due to exposed iris blood vessels due to diffuse iris atrophy. You will see that those blood vessels are also seen in the angle, and you can see that bleeding on gonioscopy as well. Right? This is what is Amsler's sign. So Amsler's sign is an exam question. Right? So we will remember stellate KPs, heterochromia iridis, no posterior synechia due to diffuse iris atrophy, and posterior subcapsular cataract. Anything else? Okay. When you talk about, if this is the presentation generally seen in the anti-uveitis, how will you treat it? What did we learn? Atypical presentation. So generally no role of steroids or cycloplegics. Right? So what we will aim is to manage the complications. Complications are the same, complicated cataract or secondary glaucoma. Of course, any uveitis can lead to this, right? So we just manage the complications. There is no very strong role of this treatment. Remember that? So we can learn this. No much role of steroids, and you may give it, but generally not much role of steroids in pediatrics, because this patient is only presenting you when there is a complication. So manage this PSC, operate for cataract, or if there is a glaucoma, manage that glaucoma. Okay? And there is one more question. If you are comparing atypical uveitis, one was JRA, one is this. They have asked you in which condition intraocular lens is contraindicated. So we will remember, we have mentioned earlier that we will remember this. We have mentioned earlier that IOL is contraindicated in JRA. Why? Because it will aggravate the inflammation. So IOL is contraindicated in JRA, but when you are treating a PSC or a complicated cataract or Fuchs heterochromic cyclitis, you can, IOL is tolerated. Okay, so for IOL is tolerated in, this is important. Okay, keep in mind, they can ask you. Fuchs heterochromic cyclitis. Done? So that was about, these are the points. And of course, if there is posterior uveitis presentation, one important point you have to remember, in case of Fuchs, there is no CME. Okay? So the patient will be presenting with posterior choroiditis, but generally no CME. That is important, and you should remember this. Okay? Yeah. Uveitis mein generally there is choroiditis, right? So we will remember choroiditis and retrolental flare. That's all. So what is very important for you to just remember this, that there is no CME, this is enough, right? So these are the presentation of Fuchs heterochromic cyclitis. Okay, so then comes another term, what is ophthalmia nodosum? This is only one line you have to know about it. It was asked quite years before, so have an idea what we are talking about. It is intense granulomatous inflammation with a very big nodule at on the iris, and this intense granulomatous inflammation, why it is occurring? This is what it is. Why it is occurring? We will say it is due to, can you see here? So this is what they are trying to show you. This is caterpillar hair in the eye. So this is the only information they will ask you. Caterpillar hair in eye, of course it is very, very rare to happen, can lead to intense granulomatous inflammation, which is called ophthalmia nodosum. So there was one question years back, so I just mentioned it as one line. Okay, keep in mind. So what is ophthalmia nodosum? Right, all of you? So that's it. That's all about uveitis and the important topics that we needed to discuss. Thank you so much. Just follow the pattern which I am telling you. Have an idea how anterior, how intermediate and posterior presents. In this condition, what is the uveitis? In this condition, what is the uveitis? That is enough. Some typical names, some important terms, learn like this. And please make the boxes, revise, it helps to revise quickly. Okay? Thank you so much. Keep smiling and stay blessed.